Good evening, everyone. I've got 6 o'clock, so I'm going to go ahead and kick us off this evening. Welcome to our joint pain webinar series. My name is Elise Hilskamp, and on behalf of Premier Health and Premier Health's orthopedic specialists, I'd like to thank each of you for attending this evening. We're very glad to have you with us. Tonight, as you know, we're here to discuss joint pain. It's a common issue for many, and you are not alone. The good news is that there are options available to help reduce your pain, increase mobility, and get you back to the activities that you love. Our physician expert, Dr. Michael Robb, will give a brief presentation this evening on those options. He will also answer some of your questions following his presentation. To submit a question, if you scroll down to the bottom of your Zoom screen, there is a Q&A button. And that is where you can click to type in your question. You can send your questions in at any time during the presentation. There is also a chat button on your screen, but please disregard that and send your questions solely through the Q&A button. That's what we'll be monitoring this evening. We will try to get to as many questions of yours as possible tonight. Just so you know, also this seminar will be recorded, so you will receive a link to the recording via email in the next few days. Likely early next week, should you want to go back and reference any portion of this evening's presentation. So with that, let's start off the evening by introducing our speaker. Michael G. Robb received his undergraduate degree in chemical engineering at the University of Notre Dame and his medical degree from the University of Illinois, Chicago. He completed his residency training in orthopedic surgery at Southern Illinois University School of Medicine. Dr. Robb then served as an orthopedic surgeon at Eisenhower Army Medical Center, Fort Gordon, Georgia, providing a wide range of general orthopedic surgery services. He was a member of the Joint Replacement Service and chief of the Hand, Elbow, and Shoulder Surgery Service. He was also a member of the teaching faculty for the Army Orthopedic Residency Training Program. Following 4 years of active duty, Dr. Robb practiced in Georgia and Ohio, and joined Premier Orthopedics in 2011. He is board certified in orthopedic surgery and maintains office hours at Miami Valley Hospital North in Englewood and at Premier Physician Network in Beaver Creek. Dr. Robb practices at Premier Orthopedics, one of the largest and highly trained orthopedic and sports medicine practices in Southwest Ohio. The practice offers the full range of treatment options from exercise and physical therapy to injections, pain management, and surgery where needed, including minimally invasive arthroscopic and robotic arm knee procedures. With nearly 30 doctors in more than 12 locations, Premier Orthopedics is ready where and when you need help. So thank you, Dr. Robb, for being with us this evening, and I will turn the presentation over to you.
Thank you, Elise, and thanks to everybody for joining us tonight. I will be brief on the presentation and move through our slides fairly quickly, so we'll have time for everybody's questions, and would encourage everybody to ask any question on their mind. That helps me understand what my patients are thinking and wondering about, so please feel free to ask any question that you'd like at the end of the presentation. Look forward to talking with you, and with that, we'll start off on our joint pain seminar. So one of the main things that brings patients to the office is joint pain. I think just about everybody has joint pain at some point. The most important thing when we see a patient, and the most important question on the patient's mind, is what's wrong, what's causing my pain? And we want to always find out the proper diagnosis first, since our treatment really depends on what the diagnosis is. Once we've established the diagnosis, next step is to consider different treatment options to relieve your problem. Always want to start out with the non-surgical treatments. Most problems we see can be treated without surgery. There's certain conditions where surgery is the right thing when non-surgical measures have not helped, or the acuity or severity of the problem is bad enough to proceed directly to surgery. But again, I'd say 80% of the patients I see, we can relieve their problem without surgery. And then when it is a surgical issue and we're at that point, there's a variety of different surgical options. There's many ways to address problems surgically, including for the arthritic knee and the arthritic hip, depending on the type of particular arthritic problem you may have. So as our joints gain life experience, or as they say, there's no cure for the common birthday. The joints have an accumulation of injuries, wear and tear, inflammation, and joint deterioration. The cartilage, or the cushion on the end of the bones at the joints, they lose the ability to absorb water molecules and become a less effective cushion. The other supporting tissues, like the meniscus cartilage, they lose elasticity with age and easily break down and tear. So a normal knee and normal cartilage looks something like this on the left-hand side. With Thanksgiving coming up, if you break open one of the joints where the leg joins the rest of the turkey, you'll see similar cartilage there. We all have similar cartilage. It's the smooth, white, glistening cartilage at the joint that we refer to as the articular cartilage. The other type of cartilage in the knee is the meniscus cartilage, and that's what people are familiar with when they say they've torn a cartilage. And the meniscus cartilage is more of a rubber gasket or bumper between the two bony parts of the knee. And the meniscus cartilage is a different type of cartilage from the articular cartilage. So acute joint pain, this refers to joint pain that comes on suddenly or quickly. This is typically a ligament sprain, a muscle strain or a muscle tear, fractures or meniscus or cartilage tears, tendonitis, bursitis, gout can come on very quickly, or a flare of rheumatoid arthritis or any other type of autoimmune type disorder that affects the joint. So these are things that patient will report it happened very quickly, came on suddenly, not a chronic problem. Conversely, chronic joint pain is a problem the patient's had for a long time. It may wax and wane, may gradually progress, may have good periods, bad periods, but it's been there a long time. Patients familiar with it, just never quite goes away and may gradually progress to become more and more of a problem to the patient. So this typically involves arthritis. Arthritis is broken down into three main categories. The first is osteoarthritis, or wear and tear arthritis. The second is rheumatoid arthritis, which is an autoimmune condition in which the body sees its own cartilage as a foreign material and tries to break it down. Lastly, if you've had an injury to your knee or hip or any other joint or trauma, the damage to the cartilage at that point can lead to further breakdown in the joint and create post-traumatic arthritis. Another cause of chronic joint pain is as a joint breaks or wears down, is the meniscus cartilage may tear and degenerate, or perhaps there's an old ligamentous injury that never quite healed right, leading to chronic pain, chronic problems in the joint. So a little bit about osteoarthritis. This is a degenerative type of joint disease. It's the most common type of arthritis, affecting 27 million Americans. It is a frequent cause of chronic joint pain and most commonly affects the knees, hips, hands, and spine. It's basically a breakdown and loss of the normal articular cartilage, or that smooth cartilage on each end of the bone at the joint. This develops gradually over time. Now, despite what's out there on the internet or on TV, there really is no cure for arthritis or something to reverse the breakdown of the cartilage. Our treatment really focuses on relieving the symptoms that the patient experiences and improving the function of the patient's joint and their life. So here's a little picture of the knee joint with age, with birthdays, where the cartilage starts to wear down. And you can see there's areas, instead of the cartilage being smooth, it's quite thinned out. And sometimes it thins out so far, there's exposed bone. And the sensation of bone rubbing on bone is very uncomfortable, very painful. Patient describes catching, giving way. The patient's body will try to get weight off that painful area. The patient will often experience a sensation of the knee giving out. And on the right, you can see an X-ray showing that there's very little space between the end of the thigh bone and the top of the shin bone. Similar as the knee, the hip joint wears out with age as well. And on the left, you can see the normal ball and socket arrangement of the hip. The ball is called the femoral head, and that's at the top of the thigh bone, and it fits into the hip socket, which is called the acetabulum. And normally that's a nice, smooth ball and socket type joint. But on the right side, you can see a similar problem where the cartilage has worn out on both sides of the joint, and we have bone rubbing on bone deep in the hip, or an arthritic hip. So suppose you have hip or knee arthritis. Who are the people that may help you out with this? Well, it's really a team effort. There's lots of different physicians that are typically involved in the patient's care that has arthritis. The family care doctor, primary care doctor, family doctor is usually the first person that will see the patient, may treat you with medication and lifestyle modifications. Sports medicine physician may see you. Orthopedic surgeons generally get involved when symptoms are not improving. If you have an autoimmune or rheumatoid type problem, you'll likely be under the care of a rheumatologist. Physical therapist will be involved in your care often, whether it be as treatment for your arthritis or after surgery. So physical and occupational therapists get involved, and more clinical dietitian and nutritionists are becoming more involved in the care of patients with joint problems from a standpoint of eating correctly and also losing weight. So some of the things that might make you think about seeing your doctor sooner rather than later. If you have persistent swelling, the knee locking up, or painful clicking with activity, that's one reason to see your physician sooner. Pain that's not improved with rest, medications, activity modification, you've done the right things, it's just not getting better, that's another reason to see the physician. And lastly, if you can't do your normal daily activities because your pain is too severe or the joint is unstable, that's another good reason to see your doctor sooner rather than later. So as far as our first step in treatment, non-operative treatment, the goal is to relieve your pain, delay major surgery, or use it certainly as a first step in a patient with multiple medical problems where the risks of surgery may outweigh the benefits. Again, the goal is to decrease pain and improve function. So first of all, weight loss. Having elevated weight across a joint certainly increases the stress on the joints and contributes to the breakdown of the cartilage, particularly if it's already starting to wear out. When you are in single leg stance going up or down stairs, your knee feels about 7 times your body weight going up and down stairs. Our knees are just not designed to carry above a certain load. It's just not going to happen long term. Weight loss, the benefits really extend beyond the relief of pain. It really helps your overall health to keep your weight at a healthy measure as measured by body mass index. So body mass index is a measure that's accepted to kind of keep a rough gauge on where you should be. And we like to see between 20 and 30. It's not the same as body fat percentage. It's the ratio of your mass in kilograms divided by your height in meters squared. So again, your goal is between 20 and 30. This is a goal that your family physician, dietitian, nutritionist can help you achieve. Weight modification, lifestyle modification. As far as diet goes, again, variety, moderation, and a well-balanced diet is most important. There's many fad diets out, but you really do need a varied diet taken in moderation. Low fat, low cholesterol. Inflammation fighting foods that can be helpful include flaxseed, omega-3 acids, olive oil, whole grains, and fiber. We should really try to have 5 to 7 serving days of fruits and vegetables, and alcohol in moderation. Uh, Really, smoking, the problem with smoking is it has effects on all your body systems, none of which are beneficial. It does affect your microcirculation, making more difficult to recover from injury, and certainly more difficult and more of a risk after surgery. So if you're contemplating joint replacement, now's the time to think about stopping smoking. Other treatments, thermotherapy, basically cold and heat. Cold is very effective, particularly with acute injuries. Reduces swelling and inflammation. It blocks nerve impulses to the joint as well as muscle spasm. Most helpful with acute flares. Ice pack wrapped in a towel, 20 minutes, 3 to 4 times a day, can be very helpful with acute injuries as well as immediately after surgery. As far as for heat, heat's a little more helpful in more chronic situations or muscle strains, may reduce pain and stiffness, increase blood flow, may increase inflammation and edema, however. Try moist towels or heat packs wrapped for 15 or 20 minutes. A lot of times, if you have a stiff joint, we'll say warm it up, cool it down after exercise. As far as medication, Tylenol is a good one to start with. It can have a significant anti-inflammatory and pain relieving effect. It's very important to watch how much Tylenol you take, no more than 3 to 4 grams a day. 4 grams is certainly the upper limit, and I tell my patients no more than 3 grams a day. So, a gram is 1,000 milligrams, and typically Tylenol comes in a variety of doses. And sometimes you'll see Tylenol or acetaminophen in other medications you may be taking. So check the label. You just want to total up the amount of acetaminophen you're taking in a day. Limit that to about 3 grams or 3,000 milligrams. Other anti-inflammatories. There's a lot of different classes of anti-inflammatories. Aspirin, ibuprofen, naproxen, diclofenac, indomethacin, Mobic, many others. Each has a different type of action on the anti-inflammatory cascade. Some work better than others for different people. So it's not a bad idea if one's not working to try a different one. It's always good to talk to your family doctor first because they can have effects on your gastrointestinal system as well as your kidney function. So before you start any of these over-the-counter anti-inflammatories, check with your family doctor. And if there is one that becomes helpful for you, your family doctor is probably going to want to check your kidney function from time to time. So always keep your family doctor informed on this. And many times it may just simply be a particular anti-inflammatory relieves your pain. It might be all that you need. Nutritional supplements like glucosamine, chondroitin sulfate, there may be some natural anti-inflammatory action, may help slow the progression of disease. I am completely neutral on these. I certainly do not object if my patients want to take them. There's not a lot of downside. If it's going to help you, you'll know in 30 to 60 days. Some people they help, some people they don't do anything, but never hurts to try. Again, I'm very neutral on them. I don't necessarily order them or recommend them, but I don't object if somebody wants to try them. The next option for you for relieving joint pain is exercise, lifestyle modification, exercise activity. Definitely helps with weight control, helps with energy. There's definitely an improved psychological and mental and social benefit to exercise. It helps strengthen your muscles, takes pressures off the joint. There's less stiffness, more flexibility. If you have a painful joint, your therapist or trainer or physician can help you with some modifications, but generally there's always something you can do that will help you get exercise. For people with hip and knee arthritis, I really like the exercise bike or swimming because that gives you aerobic energy or aerobic exercise while exercising the joint without loading the joint. So swimming, seated exercise bike, both very helpful for hip and knee arthritis. But really, whatever you like that you can do is great as well. Physical therapy, occupational therapy, the goal is to help you get back to normal. Focus is on reducing your pain, improving the range of motion of the joint. Sometimes, a stiff joint, it just won't come around with what you do yourself, even though you're doing the right thing. But there's things that the therapist can do to help stretch the joint out for you that then gives you relief and allows you to keep working on your strength and motion. Therapeutic exercise, education, activity modification. In more advanced cases, uses of a cane or a walker, they can help you with that, as well as manual therapy addressing your problem. Here's some simple exercises for hip and knee pain, just to strengthen the muscles around the hip and knee. Very straightforward. The next step that patient may want to consider, or if they're very, very sore at the time, they're having an arthritic flare in the knee, is a cortisone injection. This treats the symptoms. It does not change the disease. It doesn't make a new knee, but it may feel tremendously better so that you can then go on to your therapy and other things to do to help you lose weight and improve your motion. So cortisone injection, every few months, it can be helpful. You don't want to do them forever and ever. And once you've had 3, 4, or 5 and you're still having trouble, might be time to think about a different approach. The next option for knee arthritis, if patient has no relief with the cortisone, is to consider visco or visco supplementation or gel shots. There are a lot of different types of gel shots out there, but they're all basically what's called hyaluronic acid. They do seem to provide some lubrication to the knee, some viscoelastic support to the knee, but it's really just providing some lubrication to the knee. There's a lot of advertising out there about visco and about gel shots. I usually tell my patients that 1/3 of my patients don't see any improvement, doesn't change a darn thing, but it's worth a try. Another 1/3, they have an improvement. It may last from a few weeks to a few months. And then there's another 1/3 who are the fortunate ones that respond pretty well to this. They may do well for 6 months to a year and be perfectly happy to come in once a year and get a gel shot despite their arthritis and may get along just fine for quite some time. So everybody's different. We just see how you respond. So say you've been through everything we just talked about and your knee still hurts, your hip still hurts, and your pain is significant. You're having more bad days than good, hurts every morning. It's hard to sleep, can't do the things you want to do, can't participate in the activities you used to like to do. So you do have some other options. And generally at that point, we're looking at surgery. And the questions that you want to ask your surgeon is, when will I know is it time to have surgery? What are the expected benefits of the surgery and how long can I expect improvement? What are my limitations after surgery? And can I expect a return to normal activity? As far as question 1, when will I know when it's time to have surgery? I tell my patients that you will tell me when it's time, I won't tell you. And that is, we try everything we can short of surgery. And when we both agree it's time to start thinking about surgery, it's usually the patient that wakes up one morning and says, I've just had enough. I'm ready to have something done. So it's not the doctor that says you have to have surgery or it's time for you to have it. It's not the family that tells you when it's time. It's your decision. And when you say, I've had enough, that's when you can let your physician know, I want to talk about it. The other questions are, will I need physical therapy? What's the duration of recovery? Will I need assistance at home, and for how long? And so we really try to address all these questions before your surgery so that you know exactly what's going to happen afterwards. And all you have to concentrate is working on your recovery. The more questions you have answered ahead of time, the more you know what to expect afterwards. It's much less stressful. And you just want to be able to focus on doing your exercises and rehabbing. So as far as surgical options, arthroscopy is looking inside a joint with a small camera and then using some small devices to address some of the problems in the joint. Joint replacement is actually replacing the joint. This can be partial or it can be total, replacing the entire joint. So you may have heard of arthroscopy in the past referred to as we're going to clean up the joint. We're going to scrape out the arthritis. We'll get back to that in a minute. But again, small pencil-sized instruments are put in through small buttonhole-sized incisions about the joint. It allows the surgeon to look all through the joint and use little instruments to clean up or treat different problems within the joint. Arthroscopy, it's really not a solution for arthritis. Just doing a cleanup or that type of thing, it really doesn't make sense because the joint is worn out. Just cleaning it out and washing it out doesn't put cushion back on the joint. And you might have relief for a week or two, but then you'll be back to where you were. It's really more appropriate for when you have a torn meniscus or acute pain with some sort of acute problem within the joint. But it's really not effective for a chronic arthritic problem. So the question is, when should I consider joint replacement? Typically, it's when your pain is affecting your quality of life. You can't do the activities you want to do. You hurt more of the time than you don't. You've tried conservative treatment measures like medications, weight loss, injections, cortisone, gel, therapy, braces, maybe topicals and creams, and it's really not helping. You're still having pain. The other thing is, if you're going to think about surgery, the results should be worth going through the risks. And even though there's a lot of joint replacements done, it's a very common procedure, the risk is never zero. There is always risks involved, and those should be explained to you by your surgeon as well. So one thing I tell my patients is there's 3 reasons to have your joint replaced: pain, pain, and pain. And that's a personal decision. So knee replacements, probably close to 1 million a year now in the US, and that's probably going to be going up as our population gets older. Replacements can be a total replacement or a unicompartmental replacement. A unicompartmental or partial knee replacement is usually done when just one part of the knee is worn out, typically the inside half. And this X-ray on the left side of your screen shows not much cushion or space left between those 2 parts of the joint. And here's a typical unicompartmental knee replacement, just replacing the inside part of the knee. The rest of the knee is left alone. That's done in much less common than a total. Total knee replacement is when the entire knee is worn out. And I would say there's probably even worse looking X-rays that we see frequently, but a total knee replacement's done when the entire knee is just worn out. There's no sense to replacing part of it because the rest is going to be hurting anyway. And here's a picture of a total knee replacement where the top of the shin bone and the bottom of the thigh bone is replaced with metal and plastic. You can't really see it on the picture on the X-ray, but the underside of the kneecap is also replaced with a plastic button that articulates with the end of the thigh bone. There's a lot of different ways to do the knee replacements. 25 years ago, we positioned our cutting jigs to make our cuts on the tibia and femur bones using bony landmarks and rods that went inside the bone. After that came computer-assisted navigation, which is a little spike that we place in each bone and move the knee around so that the computer learns where the knee is and where the bones are, and it helps us adjust the cutting jigs. Lastly, and what we have started doing recently over the last few years, is a robotic assisted total knee, where x-rays are taken of your knee prior to surgery. The robot learns your knee intraoperatively with sensors, and then the robot actually positions the jig. Now, these are all just tools. They are different tools that allow us to reach the same goal, which is a well-fixed, properly positioned knee replacement. So again, can be done all three ways. All three ways are certainly acceptable. These are just some apps that are out there now for in your postoperative period, helping you get through your recovery. I'll change over now to hip replacement. If you look at the hip on the left side of your screen compared to the right, you'll see there's not any cushion left, whereas on the left, it's already starting to get narrowed, or on the right side of your screen, it's starting to get narrowed, but you can still see space and see cushion. And again, here's a total hip replacement in which the socket is replaced with a metal shell, and then the ball or the top of the femur is replaced with a ball that fits inside the shell that's attached to a stem that fits inside the thigh bone. And here's a picture after patient has undergone hip replacement, showing the shell that fits into the socket and then the ball attached to the stem that fits inside that shell. So just in review, joints give us our freedom to move and perform our daily tasks. And we probably don't think about it too much till we can't do those things. We can keep our joints healthy and flexible by watching our weight, staying active, keep moving, treat injuries when they occur. Work with your surgeon and physical therapist to determine the cause of your problem and the best treatment for your problem. And remember, most problems get better without surgery. There's many options, surgical and non-surgical, to help you with your pain and improve your quality of life. I appreciate you listening and look forward to answering any questions anybody may have.
Okay, just as a reminder, if you hover your cursor over the bottom of your Zoom window, there is a Q&A button. That is where you can go ahead and type in your questions that Dr. Rob will begin answering now. So a first question that we have is, should you have both knees replaced at the same time?
That's a good question. That comes up frequently. I would say it's most frequently done in patients who are younger and healthier. So if a patient is older and has a lot of medical issues, particularly if there's heart or pulmonary issues, or they can't really tolerate a long time under anesthesia, might be better to do one at a time. Younger, more healthy patient, or after a discussion with your surgeon, doing them at the same time is an option. I'd say the majority is one at a time. I generally tell my patients, if one knee hurts more than the other, and it's very clear that it hurts more than the other side, but they both hurt, is always do the bad one first and then wait and see how you do. Because when that knee becomes your good knee, it's not as much work for the other knee. And the other knee may do just fine for quite some time before you have to do anything. If they're both really, really bad and you're really having trouble, it is an option. But I personally prefer one at a time unless there's a compelling reason to do both at the same time.
Thank you. Our next question is there a knee load with using an elliptical machine?
There still is a knee load with an elliptical, but the elliptical still has armrests that you can offload some of your weight. So, elliptical is probably better than jogging or running because you can at least offload some of your weight through your arms onto parts of the elliptical. That goes for a treadmill as well. So you want to carry some of the weight through your arms and offload the joint a little bit, but it's certainly better than jogging or running.
Our next question is metal the only option for a total hip replacement?
As far as a total hip replacement, it's pretty hard to conceive of doing it without some metal. As far as the loads that go across the hip joint are tremendous, and it really requires something strong enough to bear that load. The hip replacement as it is now, the shell is metal, the stem is metal, but where the ball fits into the socket, that's usually a high molecular weight polyethylene or plastic. But as far as doing it completely and not using metal, it sounds attractive, but they've just not been able to identify anything that could carry that load without breaking down. They did try a lot of different substances when hip replacement was invented, and that was one of the main problems when they tried other things until they came up with what we do now.
Okay, our next question is a conformist knee brand replaced robotically?
I don't use the conformist brand. I'm not familiar with it. I know that some people use conformist. I don't know if it's able to be used robotically. Most of the robots that are being used now are provided by a company that manufactures the knee. So company A has robot A with knee implant A. Company B has robot B with knee implant B. I don't know if Conformis has their own robot or not.
While we're on the topic of robotics, who is a candidate for robotic joint replacement?
Good question. You know, as I said before, the robot is a tool that allows us to position our cutting jigs. So the robot is very helpful for somebody that has significant deformity, you know, even beyond the typical worn out knee. It's real helpful for somebody who has a significant post-traumatic deformity where we can visualize what we're going to do on the computer before we even make a bone cut. And that allows us to adjust our jigs during the surgery to optimize what's done. It's very helpful for that. I would say for other patients that have the standard worn out hip or knee or something we see commonly, it may be helpful. It's really up to your surgeon's preference. It's helpful on those as well.
Next question is, I have arthritis in my knee and I have had gel shots. At this point, I'm doing pretty good. I have heard about stem cells for knees. What is your opinion of this?
Well, you know, I think, you know, one thing, the stem cells will lighten your wallet and probably lessen some of the force across your knee. But beyond that, it's not necessarily approved or proven. The American Academy of Orthopedic Surgeons is non-committal on it. They have not yet been approved as far as going through the scientific process and peer-reviewed studies showing a clear improvement with stem cells over other treatments. That being said, anecdotally, I've had several patients that have had stem cells done elsewhere with mixed results. You know, some seem to do well with them, some it makes no difference. That's another thing I'm pretty neutral on, in that if the patient wants to try those, I don't object. I just wouldn't necessarily guarantee a result or tell them to expect anything in particular. It really depends on the patient's response to it.
Our next question is, what causes bone spurs and how do they disrupt knee movement and comfort?
So that's a great question, because the bone spurs, you know, we can feel them, we can see them on the X-ray, and typically people are like, what, you know, what's going on? Why do I have this spur? And the thought is that when your knee starts to wear out, your body tries to increase the surface area of the joint to spread out that force and decrease the amount of force per unit area. And so the spurs can form from that, or from traction on the tendons around the joint. If they get big and bulky, they actually kind of impinge or press on some of the ligaments around the knee. And as they grow, they can make it difficult to get the knee straight. So, once the arthritis is advanced and the spurs are getting larger and larger, they definitely have a mechanical effect on the ability of the joint to move.
Next question is, what is the lifespan of an artificial knee?
The technology has really come a long way, particularly with the materials that are used in the knee replacement. The goal now is we like to see 95% survival rate at 20 years. That means that the knee replacement lasts 20 years, 95% of the time. Now, the lighter or the thinner, the more active the patient, the better. It's a little different story if you're a smoker or your BMI is elevated. Again, it may not last as long if that's the case.
The next question is ischial fold pain common with hip arthritis? This caused me to get an X-ray on Friday.
Can you repeat the question? I'm sorry.
And I might be mispronouncing it, is ischial fold pain common with hip arthritis?
So I think what the person asking the question might be saying, by the ischial fold, I think of either near the buttock or just below the buttock versus in the groin, the fold that we have in the front of the hip. The feeling is that an X-ray is a good idea to check that type of pain out, because if you do have an arthritic hip, sometimes you'll feel the worn out socket pain in the back of your buttock, and then the worn out ball pain you might feel in the front of your groin. There's a lot of other things that can cause ischial fold pain, and that's why your physician will talk with you and examine you to determine what that may be.
Is using hyaluronic acid injections forever better than a replaced knee?
Yeah, that's a good question too. I will say if a patient gets a gel shot or a hyaluronic acid shot once a year, and they come back in a year and we talk about their family and what their grandkids are doing, and they do fine for another year, it's pretty hard to argue with that. So if you're getting a year's worth of relief, there's no reason to really change that. If you're needing them more frequently every 6 months and they're really not doing that much for you, or just partial relief, I would have some concern about that amount of artificial substance going in repeatedly. So in that case, I might say, after 3 or 4, maybe not continuing that. But if it's once a year, I don't have a problem with that.
There's a follow-up question to the bone spurs question, Dr. Rob.
Yeah.
Are bone spurs not between the joint, but on the edge of the joint?
That's exactly right. Yeah, the bone spurs are kind of like on the sides of the joint. Sometimes people will get bone spurs under the kneecap that actually kind of get into the joint and limit your ability to bend your knee straight. So most of the time they're on the periphery or the margins of the joint is where they form.
Our next question is, my sister-in-law had her knee replaced and it became infected. She had to have it removed and undergo a few weeks of IV antibiotics, then recently had the surgery repeated. How common is an infection like this?
I'm sorry to hear that your sister had to go through that. Like we were saying earlier, there's risks with any surgery. And a big part of before going through surgery is what we call optimizing your medical condition. And even people who have optimized their medical condition can have an infection occur. So the things we like to see optimized before surgery, and I don't know if any of these apply to your sister or not, is if a patient is diabetic, we really would like to see your hemoglobin A1C 7.5 or lower. If you smoke, we'd like you to quit smoking for at least 3 months. If your weight is high, I like to see your BMI 35 or lower. Unless you have a pretty skinny leg, we can go a little higher. If you have other cardiopulmonary issues, your family doctor needs to clear you. The other thing is your dental health is very important. If you have a dental infection or any sort of dental problem, all that has to be taken care of before you have your hip or knee replaced. So we require everybody to see their dentist and make sure they have no infection in their mouth, and also make sure if they have dental work to be done, that's all completed well before your surgery. If you have rheumatoid arthritis, your medications for rheumatoid will have to be stopped for a while. So there's really quite a bit of things that need to be done before surgery to make sure that you have a healthy environment for that new joint to go in. And again, even if all that's done, it can still happen. Germs can get into the bloodstream and get into the joint and develop an infection, even if everything's done right. It's very rare. It's less than 1%, but it's a big deal. It's really a big deal, and it's something that if at all possible, we want to avoid. And I've had some patients, they're upset that we're not doing their joint right away, and we're requiring all these things first. And it just takes some education to understand why. But it's very important to optimize your medical condition prior to going through a hip or knee replacement.
Do you do cortisone shots in the hip? If so, would you need x-rays before doing cortisone shots to see if pain is caused by injury or arthritis?
That's a real good question. So yes, we do cortisone shots into the hip. That's assuming that the proper diagnosis has been made first. And so you would need x-rays to determine if it's an arthritic problem, as well as a physical exam. But assuming that your hip problem is from hip arthritis, a cortisone injection into the hip is helpful. And those are typically done under ultrasound because the hip is such a deep joint and there's important structures around the hip. We want to visualize where the needle is going when we do that injection. So the ultrasound machine is used for that. It's not necessary for the knee because the knee we can palpate and feel exactly where the needle's going.
Our next question, does advanced age disqualify a patient for surgery?
That's a great question too. I've had some 65-year-old patients who are 80 years old, and I've had some 85-year-old patients who are 60 years old. So it really depends on your physiologic age. So the answer is no, advanced age does not disqualify you from a knee or hip replacement. You might need a bit more optimization before going through it, but if you're of sound mind and have a support system to help care for you and understand and can optimize your medical situation, it does not disqualify you.
This next question is really two questions, so I'll start with the first part. Are joint replacements usually glued in place during surgery for the older patient due to less active bone growth and repair activity?
That's another really good question. So for the knee replacements, typically those are cemented in, and so that's similar to a glue. So the bone cuts are made, and then the components of the replacement fit very snugly, but we place a glue or a grout or cement between that for that very reason. Sometimes in younger patients that have very robust bone, some knee surgeons will do a press fit or a uncemented knee. As far as the hip goes, we generally cement hip fracture patients that need a hip replacement because by definition, their bone is weak. They've fallen and broken their hip. Usually that bone is not real healthy. So we'll cement the hip stems on a fracture case. For the patients that are going through a hip replacement, typically those are press fit without cement, unless during the surgery we feel the bone is just too weak or too thin. It's very easy to switch over to a cemented stem. It's rare to cement the cup but occasionally that's done in tumor cases or other types of problems.
Then the second part of this question was, what medications are used to help minimize blood clot development?
Another good question. So anytime you have major pelvic or hip or knee surgery, you are automatically at risk of a blood clot. And so we want to take measures to lower that risk. The simplest measures are getting you up after surgery, walking right away. The muscle action helps pump blood through. We also use support hose on the legs and also some devices that help squeeze your leg muscles to move the blood through. But also for hip and knee replacement, pharmacologic anticoagulation, meaning blood thinners, that's important as well. So there's a variety that are acceptable. Some surgeons will use aspirin. Some surgeons will use Coumadin, which is a pill blood thinner. And some will use Lovenox or enoxaparin, which is a shot you get in your belly skin for about 21 days after surgery. There's different options for that depending on your medical situation.
What if you have lymphedema in the legs for total hip replacement? Can you still qualify for surgery?
You still could, and lymphedema is a collection of lymph fluid rather than your venous system, so it's a different type of circulation. I would suggest maybe having consultation with a vascular specialist before going through the hip or knee replacement, because it's likely that the lymphedema could be made worse. So whatever could be done to improve your situation with respect to the lymphedema before and after, we'd kind of want to know what the vascular doctor thought about that. But it wouldn't necessarily disqualify you.
What can you tell me about psoriatic arthritis? Only one knee is affected by the arthritis now.
So psoriatic arthritis is another type of autoimmune arthritis and associated with psoriasis, rash, joint pain. If you have psoriatic arthritis, you are likely under the care of a rheumatologist. And there's some very good medications now that we didn't have 10, 20 years ago that treat these autoimmune arthritis problems like rheumatoid arthritis, psoriatic arthritis, et cetera. Oftentimes the medications that your rheumatologist can provide really do a great job as far as pain relief and improving your function. So, we always want to have you maximize what you've done with your rheumatologist first. You may not need our help, but if you are working with a rheumatologist and the joint's just worn out, we work with your rheumatologist then, because some of the medications you're on would need to be stopped before and after surgery, because they are by definition immunosuppressives. They decrease your immune response. We want you to have an immune response after surgery to fight off any potential infection. So hopefully that answers the question. If not, let me know.
Do you deal with heel spurs at the back of the heel?
Heel spurs are something we see commonly. I don't treat those quite as often as I have in the past, but it is something that brings people to the orthopedic office frequently. We can refer you to a foot specialist or a podiatrist that specialize in that type of problem. But with aging, we see a lot of people with that type of problem as well.
Is taking Prolia a problem with knee replacement?
It's not a problem. If you're taking Prolia, you are likely osteoporotic or have osteoporosis. We would probably want to consult with whoever prescribes your Prolia to make sure they're in agreement with you having the surgery, but that doesn't necessarily change what we would do.
I'm going to make a last call for questions. We're at about 5 till, and I have one more question in the queue. And if no other questions come in, then we will wrap up here shortly. So the next question is, does osteopenia disqualify a patient from a knee replacement?
It does not. Osteopenia, it just means that your bone is thinner. So the osteoporosis, osteopenia, it really doesn't refer to the joint itself. It just means the bone on each side of the joint is a bit thinner. Uh, because you have osteopenia or osteoporosis, you can still get the same arthritis as anybody else. It just means that when you have your hip or knee replacement, we will likely cement it, particularly for the knee, but it doesn't otherwise have any bearing on what we do.
Okay. Oh, one question came in at the nick of time. Is the goal of post-surgical knee or hip therapy to restore flexibility and strength moving forward?
Those are the two main goals, is to get your flexibility and strength up to speed as quickly as we can. So, sometimes we'll also do what's called prehab, where we'll send you to therapy before surgery so that you will be aware of what's expected after surgery. And the stronger and more flexible you are going into the surgery, the stronger and more flexible you are coming out. Now, sometimes the joint's just so bad, it's only going to move so far, but you do the best you can prior. And then, once the bone spurs are gone and the knee works again, we get you into therapy quickly to work on your motion and your strength. That's very important.
Okay, we've reached the end of our Q&A. Thank you so much, Dr. Rob, for your informative presentation. We really appreciate your time and expertise. And I want to thank all of you very much for joining us this evening. I hope you found the information shared very useful. We feel very privileged to be with you tonight and hope that you consider us for any healthcare needs you may have in the future. If you'd like to learn more about Dr. Rob or his practice, Premier Orthopedics, you can visit premierorthooh.com. More information about Dr. Rob can also be found on his bio that was sent along with the information to access tonight's event. Should you have additional questions or would like to make an appointment, his office phone number is on both the practice website and on his bio. Last but not least, as a reminder, this seminar was recorded. We will email you a link to the recording should you want to go back and listen to some or all of this great content again. As soon as it's available, likely early next week, we will share the URL to access the recording. And along with the recording URL, we will also share a link to a short survey on tonight's program. We very much value your feedback and would appreciate if you could take a few minutes to share your thoughts with us. And with that, we wish you all a good evening and thank you again for joining us.
Happy Thanksgiving.